Hello. Hi again. My name is Felice D'Arco, and this is my YouTube channel dedicated to pediatric neuroradiology. Today, I would like to share with you the presentation that I did recently in the European Society of Pediatric Radiology annual meeting in beautiful Seville on abusive head trauma. And what I tried to do is to share an approach for the real-life radiologist. And these are the lecture outline. I will show, of course, the basic of neuroradiological assessment or in cases of suspicion of abusive head trauma. But most importantly, I will try to show you how I report it. So the wording is very important, and we need to balance our report in order to, if there is a suspicion of abusive head trauma, to state it clearly, but also to limit our assessment to what the images shows. I will show you some controversies and how to approach them, and then I will show you a special case that we recently encountered at GOSH. This case, for this case and for other cases that I show you that are not published in literature, I slightly changed the demographic and slightly manipulated the images in order to protect the privacy of these patients. But anyway, I ask the permission when necessary. On top of that, there will be some screenshots of some papers because, of course, I cannot go through all the details, but to know the literature and the nuances of the literature is really important. In this case, I only have 20 to 30 minutes, so we'll try to give you also some important references. By no means I consider myself an expert. This is my disclaimer. There are people that for 20 years have been studying this specific clinical radiological problem of child abuse, and some of that people are members of the task force, abusive child abuse task force of the European Society of Pediatric Radiology. Please check the website out. And also there are members of the Royal College of Pediatricians and Child Health that provided a lot of interesting resources. On top of that, speaking of the task force, there was a session in the meeting where basically the task force presented imaging guidelines consensus that will be coming up soon. So please check it out to know how to scan and follow up this patient. Now, first paper has been written by my lovely colleague, Dr. Astik Biswas, and basically summarize all the findings. But the key point I want to stress, they're very important, that abusive trauma is not a radiological diagnosis, but is something that follows a multidisciplinary approach. But nevertheless, we as radiologists have important role as a sentinel. So we need to trigger a lot of discussion and strategy meetings in order to protect the children and the families. And very important that this is the definition. Abusive trauma is an injury of the skull and intracranial content of an infant or a child younger than 5 years old. And there are several mechanisms. I will go to that later, but it's important that we need to raise the possibility clearly, but we are not writing a legal determination of the intent. In other words, we are not judges. And also there are several biomechanic mechanisms involved which account for radiological complexity. Now, what are these mechanisms? Of course, there is a blunt direct trauma. We expect fracture, we expect intracranial bleed, especially epidural. And this is it's very difficult to distinguish between non-accidental and accidental injury, but I will come to that later. The impulse loading, what we used to call shaken mechanism, is characterized by translational, angular, and rotational movement, normally movement of the brain relatively to the skull, and I will show you a video in the next slides. But on top of that, there are some mechanisms not completely understood, probably related to apnea, compression of the thorax, cardiac arrest, and so on, which may create hypoxic ischemic damage to the brain. And the most important thing is that these mechanisms are complex, but also we do not have reliable models to explain all the changes, precisely all the changes, and to evaluate all the forces involved in this shaken impact kind of injuries. So what are the basics? Let me show you this video. This is from YouTube, basically the theory is that because the head of an infant is larger than the body, when we shake an impact, the brain moves relatively to the skull, which is fixed, and this creates bridging brain ruptures that accounts for the subdural, mainly subdural or intradural hemorrhages that we see, and also the retinal hemorrhages. And I want to stress, and I will come to that later, that retinal hemorrhages in abusive head trauma are very, very specific. And of course, this movement and the compression of the thorax will also explain some complex damage, direct damage of the brain by way of ischemic injury, laceration, and so on. So this is an infant with enlarged x-axial spaces that are normal, and we call benign enlargement of subarachnoid space, where the bridging vein courses through this space and are intact. All right, so when we see something like that, this is normal, and it is due to the fact that, especially when the child is not mobile, and the granulation of pacchioni are not developed, the brain takes some time to catch up relatively to the skull growth. But this case is different. This is a child who is not normal neurological, is profoundly abnormal. And if we look at the density of this collection, it's different from this density here, which is CSF. So this is a subdural collection. And if we look the same on MRI, there are no bridging veins. So this is the hallmark of the subdural space, although some pathologists claim that this is actually rather intradural space, but this is less important as far as radiological daily approach is concerned, so I will not go there. And in this specific case, if we go a bit cranially, we see hyperdense blood and also hypodensity in the brain. So this is abusive head trauma with mixed density. It's very, very important when we see something like that, we trigger, we suggest the possibility of abusive head trauma, but remember, mixed density of subdural hematoma does not mean different insults in terms of timing. We have the CSF washing out these extractor places constantly, so it's normal to have this mixed density. And never use, and this is a consequence of this fact, acute on chronic. So these are my first two pearls for approaching this. Now, what are the other radiological findings to look for? Rupture of the veins, the so-called tadpole signs or lollipop signs. The veins here are the theory is that they get broke and they develop this thrombus that gives you the appearance of the tadpole. So this is supposed to be very specific for abusive head trauma. Parenchymal vein injury can be HIE, as in this case, and laceration with blood. Retinal hemorrhages, we can see on SWI, but we do need our colleagues, the ophthalmologists, to confirm not only the presence of retinal hemorrhages, but also these specific retinal hemorrhages. They are multi-rayed, numerous, extending to the ora serratum, associated with retinoschisis. So the retinal hemorrhages that have been associated with non-accidental injury are very specific and they fade away quite fast. So when we have something suggesting an abusive head trauma, please flag it immediately so they can do ophthalmological examination if not done before. And also look at the spine. In your MRI protocol, you need to scan the spine. And because spinal subdural hemorrhages have been described, again, as linked statistically with abusive head trauma, but also ligamentous injuries being described as part of this constellation of findings that suggest abusive head trauma, remember to use T2 stir, at least in the cervical. How do I report? I strongly suggest you to read this consensus statement of abusive head trauma endorsed by several societies, including the European Society of Pediatric Radiology. But what I do is that if I have like a shaken impact mechanism, so I see the so-called triad of subdural hemorrhages in the context of retinal hemorrhages and encephalopathy with damage in the brain, I would finish my report with this phrase that is suggestive. This constellation of findings are suggestive of abusive head trauma in absence of suitable alternative explanation, because there are mimics we should be aware of. If there is an impact loading, the situation is a bit more complicated, but as a general rule, when we see complex, bilateral, depressed fracture, intracranial damages, this means that there was more force implied in the traumatic mechanism. And of course, more force can be like accidental or non-accidental, but what I write is findings imply significant trauma, and in absence of appropriate history, abusive trauma should be considered. Remember the mimics, that's another paper you should read, again, from my colleagues, Dr. Mankad and another eminent neuroradiologist. There's a beautiful installation by Banksy called The Elephant in the Room. And just to introduce the fact that there are controversies, there are so-called negationist papers, and they will be quoted in tribunal. They will be, you will be asked about these papers, and you need to know how to tackle. Because, you know, there are different approaches, and we should not be dogmatic. We should scientifically try to understand what this paper says and what they get wrong, what flaws they have. Most important paper is the so-called SBU report from this Swedish group that basically try to evaluate the so-called triads and the value in the papers that identify the triads are as linked with high possibility of abusive head trauma. This is what they use as systematic review, but they basically said they don't comment about the triad not being linked to abusive head trauma. But what they say is that there are no enough scientific evidence to assess this diagnostic accuracy and of the triad, and low quality evidence suggests that the triad will be associated with traumatic shaking. Now, this triggered a lot of responses. These are some of them, and you should really download them. Some from the ESPR and some from the RCPCH, which is this one from RCPH is one of the best in my personal opinion. And these things are so important that they hit the news, okay? So the literature is out there. Social studies police colleagues and parents will ask about this. So we need to read it and know what are point by point the flaws or the SBU report or other similar reports, and also to understand as far as we can go as a clinician in our diagnosis. So the Royal College of Physicians and Child Health responded to this paper in a point-by-point fashion, and they say that in the paper there are critical methodological flaws, and you know they consider this triad like an isolated associated with traumatic shaking, which is the wrong question, because we have seen how complex are the dynamics of abusive head trauma. And so isolated traumatic shaking is a novel entity, which makes very difficult to select the paper in the review. And also some of the references are misquoted, and I will show you some example. And this is another paper from Professor Levin explaining that about the retinal hemorrhage that also you should download. But staying on the previous paper, the triad and the encephalopathy are never fully defined in method, so search term bias. And admitted or witnessed traumatic shaking is really unrealistic gold standard, because this means that in the absence of admitted or witnessed traumatic shaking, there was not shaking at all. But we know that the large majority of the cases are unfortunately not witnessed and not admitted. As far as Professor Levin reports goes, no, before that, sorry, minimum 10 patient threshold, but they included case report as a mimics, which is kind of inappropriate, really. The retinal hemorrhages, as I said, needs to be very, very specific for abusive head trauma, but they do not take into account the type of retinal hemorrhages. So this makes the mimics very, very, the mimics do not apply actually to the cases of suspicious abusive head trauma. So these are just some examples, but just to say that this SPU report is not perfect. There are methodological flaws, but you need to know them if you are dealing with a case like that. So the pearls for you is that know that there are a lot of flaws in the SPU and other similar paper, but you need to know the literature and really the scientific approach of going point by point through these papers and try to understand what makes sense and what doesn't make sense is very, very important. This is the table regarding the mimics. Now, even considering the triad, I've highlighted the only 5 cases where all three entities are present. And remember, this includes case report as well. But if you look in details, what are they? We have delta storage pool disease, which it's easily to diagnose. We have a K vitamin deficiency. I will show you some example. Hepatitis, a case of hepatitis that I will show you in the next slides. Vascular malformation, again, easily diagnosed on radiology. And HLH, which is hemophagocytic lymphocytosis, which again, it looks more like a tumor with the involvement of the cerebellum and the brain, and really cannot pose any diagnostic challenge with abusive head trauma. This is the paper they refer to for a triad. Clearly, they didn't see this paper because this is a child where ultrasound revealed unilateral large subdural with midline shift and brain edema. And this is the post-mortem. So this is very, very different from the patchy area of bilateral subdural with tadpole sign and retinal hemorrhages, the typical of abusive trauma that I showed you before. So really, this is not a mimic. So keep things in perspective. Look at these 3 cases, all with subdural, all retinal hemorrhages, all infant. Do they look similar to the one I showed before? Is there any tadpole sign, bilateral, patchy areas? No, this is unilateral. There is, of course, encephalopathy, subdural, intradural, and there is hydrocephalus and unilateral retinal hemorrhages, which do not fit the abusive trauma. These were all vitamin K deficiency. Again, if you just read a report, yes, there is a triad, but the clinical radiological context is completely different. What about the timing? This is another paper that you would like to have in your archive from AJNR. And just to show you that the hyperdense blood is present up to 2 weeks. And this is very important because hyperdense blood doesn't mean acute unless you have a clinical correlation. On top of that, this is not homogeneous hyperdensity, but as I showed you before, and I will show you in a bit, a lot of data say that most of the acute subdurals present as a mixed density blood. So bottom line is that please do not date, not even in CT. Also, remember, you can have a rebleeds in large subdurals with membranes that makes even more complicated, and even beyond the 2 weeks cutoff, the possibility of hyperdense blood. So don't date the blood based on imaging. One important thing is that the only thing that seems to, be we seem to be able to date are the presence of membrane. That means more than 10 days, and there are pathological studies. So if you see clearly membranes in large subdural, this may represent something more than 10 days. If you see the, and this is an example of membrane from the same paper. These are other two important papers on timing, just to show you the overlap of density and MRI intensity, very difficult to date precisely, and also the amount of mixed density collection in the first 6 days. So the authors of these two papers conclude that neuroimaging studies at this time are not likely to be able to accurately pinpoint the specific time of injury, and mixed density, once again, subdural are common on initial scan, more than 60% of the victim. So again, your pearl is you cannot date the subdural, but of course you can ask the clinician when the symptom starts, how the symptom looks like, but this is more for the expert in tribunal than for the radiologist. Now let's go to the fascinating field of fractures. So this is a beautiful book. It's a bit old, but it's really amazing in terms of literature review. And what they say when it comes to skull fracture is that multiple complex depressed fracture, growing fracture, large than 3 millimeter with bilateral and so on, are more likely to be associated with non-accidental injury. But I would rather say more likely to be associated with an impact implying significant forces. Actually, there are some papers, like this is a paper in German, done in the 60s. And before the ethical committees were created, they basically took some infant that passed away, and they dropped them from a low high, and this they check what kind of fracture they would see, and they saw that it was possible to have bilateral fractures or multiple fracture even from a small fall. On top of that, if you keep reading the literature, they say that simple linear fracture, especially in the parietal bone, are the most common type of skull fracture in both abusive and non-abusive traumas. So it's very complex, because you can have linear fracture in abuse, you can have complex fracture in non-abusive accidental falls. So be careful when reporting fracture. Ask for a clear history, and what you can just say is that the history doesn't fit with the very, very bad appearances of the skull. And this is why I report like that. The findings imply significant trauma in absence of appropriate history. Consider abusive trauma. Most important thing, technical aspect, consider a 3D reformat. Ask your radiographer to do the 3D reformats, very helpful. And know your developmental anatomy, especially the skull base has a lot of variant or suture. So middle occipital suture remnant is normal. Mendosal suture, Wormian bone, know your developmental anatomy. This is a beautiful photograph by Karina Zero on complexity. And speaking about complexity, of course, as I say, the history needs to be compatible. There is no such a thing like a killer sofa. So if a child, if the family reports that the child fell from the sofa and the brain looked very bad with all the radiological characteristics I've shown you before, well, that's inconsistent. But consider the complexity of the mechanism of injury. This paper shows 7 variables that have been associated with abusive head trauma, including respiratory compromise, bruising, subdural, complex skull fracture, abnormal skeletal survey, retinal exam, and brain HIE. And look at that. If we have 3 of them, bruising, subdural, and survey, the probability of abuse without the other 4 is less than 50%. If we have only complex fractures, the probability of abuse, because we are reasoning in terms of probability here, is very, very low, less than if we don't have any of these variables. So remember, do not jump to the conclusion just because you have subdurals. You need a multidisciplinary approach. So we come back to the original quote from Dr. Biswa's paper, that we need to raise the concern and trigger a multidisciplinary approach that needs to go into details. Again, keep things in perspective. Now, this is my son here. He's 1.5 years and he loves try to jump from the stairs. And this is why we bought this kind of protector, like there's a small gate. But of course, if you consider that a small children falling from 15 steps on a stair, this is a complex mechanism. This is not a fall from the sofa. So if you read the literature, you will figure out that 1/5 of children that were reported as falling from stairs had very, very significant intracranial injury. Again, my son, he loves to for me to move him up and down from my arms. He's having a lot of fun. But again, I should be careful because the most serious accidental injury that are being reported are reported from fall from arms. So this can simulate enough force to suggest an abusive head trauma. So this is very, very important. And also very important, all the different seat, baby bouncer, high chair, they are complex to interpret. There is limited literature, but serious injury have been described. Again, a lot of literature is from this book, but my pearl for you is that if the mechanism of fall is complex, you need a case-by-case consideration. It's very, very important. So what is the summary so far? Don't date the subdural, be careful when reporting fracture, know the controversies in literature, and keep in mind the complexity of mechanism of injury described. This is a real life case. I changed the demographic and the images, and some images are from internet. And I asked the social service to show in an anonymized fashion because I think it's important. This is a child who came for 18 months old boy who came for mastoid CT for suspicious cholesteatoma on the right here. And these are the images, and what you can see is basically that there is fluid in the mastoid and the middle ear. However, the ossicles and the scutum, normally a cholesteatoma should be here, are intact. Interestingly enough, if you speak with when I spoke with the ENT person said that the child was bleeding from the ear, which is very concerning, extremely unusual. And looking carefully, the otic capsule and the carotid canal were eroded. I also saw some small pieces of what I interpreted as a piece of bone, probably after this erosion. But the otic capsule is the hardest bone in the body. So what can erode the otic capsule? We will come to that later. Looking at the MRI, because of course, this was so unusual that I threw the book at the child didn't have the carotid anymore because this inflammatory fluid went all the way into the carotid space and occluded as a secondary inflammatory phenomenon the carotid. But there were no areas of diffusion restriction to suggest cholesteatoma or aggressive tumor. So again, what is the that can cause the erosion of the aortic capsule? Well, fungal infection, very aggressive, but this is really, really not the case. The child was not immunodepressed. There were biopsy taken were negative and so on. There were no evidence of cholesteatoma, nothing to suggest granuloma or foreign body granuloma, for instance. And the tumor, I remember, when I had such a difficult case, I spoke with I discussed these images with an amazing head and neck pediatric radiologist, which is Kelly Robson from Boston Children. And she said, well, we have seen rarely a little tumor eroding there. This is so rare, there is no evidence for that. So we had no clue, okay? 2 weeks down the line, marked improvement of the skull base, but now the child has orbital cellulitis, mainly anteriorly, and the rest of the skull base is pristine. So what inflammatory process jumped all the way, staying on the same side from the mastoid to the anterior orbit? Again, we were puzzled, not only, but the angiography was negative for pseudoaneurysm, the bleeding stopped, and there were no evidence of coagulopathy. So we could not make sense of these things. And every time the things do not fit together, that's actually something that needs to be considered. 2 weeks later, there is marked improvement also of the orbital cellulitis, but also there was a pseudocyst close to the globe, which was not where the ophthalmologist biopsied. So at some point, history of social service problem surfaced, and we asked the ophthalmologist to have a look, and this is from the internet. But we had abrasion, traumatic abrasion of the sclera and of the globe, which justified this bleeding also from the orbit. So although this is not a radiological diagnosis, but when you have eliminated all which is impossible, then whatever remains, however improbable, must be the truth. And this probably was a granuloma for foreign bodies. The social concern were extremely strong, and we hypothesized, and again, we just flagged the possibility of medical child abuse, also called Munchausen by proxy. Again, this is based on multidisciplinary approach, and it's not a radiological diagnosis, but at least to say, well, this doesn't fit anything I've seen before. Everything is possible. Please consider also that and investigate. It's a fair way to, protect the child and also protect the family. And it's just to say that the child can be more susceptible in many ways. So please consider also this rarer form. That's my child using the force. These are my acknowledgement. And if you see this presentation before November 2024, please consider to join the first European Pediatric Neuroradiology Congress in Budapest. And with that, I would like to thank you very much and see you next time.